Welcome to Better Sex, where you get the information and inspiration to create and enjoy your best possible sex life. Join your host, sex therapist Jessa Zimmerman, as she brings you expert guests, helpful tips, knowledge, and strategies to improve your intimate relationships. And now, your host, Jessa Zimmerman.
Hey, it's Jessa here with another episode of the Better Sex Podcast. I'm so glad you're here with me. I appreciate your support and your listening. I hope this is a good podcast for you, that it's making a difference, that you're learning something, that you feel inspired, or that you're getting helpful information to improve your own sex life. I picked an important topic, I think, for today. We're going to be talking about prostate cancer, and especially the sexual impacts of the treatment of that. Obviously, not all of you are going to encounter this, thankfully, in your lives, but some of you have, or some of you will. And having the proper information about various treatments, you're going to get that from your physician. But understanding how various treatments might impact your sexual functioning and getting ahead of the curve on what's called penile rehabilitation is really crucial to retaining sexual function or regaining sexual function, and especially to maintaining an intimate relationship. So it's important that if sex matters to you, if you're in a partnership or not, and you want that, you need to be paying attention to this early. So my guest today is Dr. Daniela Wittmann, and she's an associate professor of urology and adjunct associate professor of social work at the University of Michigan. So she uses mixed methods to understand issues in cancer survivorship care, and especially to evaluate interventions designed to help patients and their partners' sexual outcomes. So she's got a specific area of interest in sexual health and quality of life in cancer survivorship. She's really dedicated to this. I cannot imagine a better guest to come in and talk about this with me for your benefit. I hope you get a lot out of it. Daniela, thank you so much for being with me today.
It's a great pleasure. Thank you for inviting me.
Yeah, I think it's a really important topic, and I'm excited to share the information with the listeners. Let's start with prostate cancer. What kind of symptoms might people have, or what are the recommendations around screening for that?
Okay. So prostate cancer is typically completely asymptomatic. So people don't know that they have it unless it's already metastasized and people start having perhaps bone pain.
Okay.
So when it's localized, they will not have any symptoms, but they may be screened by having their PSA tested. That is the prostate serum antigen tested in a blood test.
Okay.
Which routinely in the last maybe 20 years, primary care physicians used to do until about 2012, when the U.S. National Task Force recommended that it not be done so routinely. But anyway, it gets screened through PSA. It's a blood test. And when it is rising in the man's body, then there's a concern that there may be prostate cancer. And then men have a biopsy to find out whether there is actually any cancer in the prostate. Sometimes that is done with the help of an MRI. And once it's detected, then there are a number of treatment options, which I can go into if you want me to. But that is how prostate cancer is typically screened for.
Okay. Well, yeah, maybe you could just briefly talk about the treatment options with an emphasis on any that would affect, sexual functioning.
Yes. There are a number of options. If the prostate cancer is non-aggressive, and it's very localized and in a small portion of the prostate, typically men are advised to go on something that's called active surveillance. It just means that the follow-up with PSA goes on and there are repeated biopsies or MRIs to help detect prostate cancer if it becomes more aggressive and if there's an indication for treatment. That type of approach does not lead to sexual side effects.
Right, because they're just monitoring, right?
Because they mostly just monitor,
Yeah.
yes.
Okay.
And when men have to go for active treatment and it's still localized, even if it is fairly high risk, fairly aggressive, as long as it's localized, the treatment is called definitive, and it can be by radiation, and there are several forms of radiation, or by surgery. And in those cases, side effects do occur.
Okay.
With surgery, the sexual side effect is immediate. The prostate is taken out, and the nerves that are responsible for erections are damaged, and so men experience erectile dysfunction. There's a small proportion of men who experience it less, but majority of men have some form of erectile dysfunction.
Okay. So that's almost a guaranteed effect of the surgery.
Almost a guaranteed.
Okay.
These days, there's a desire and effort to spare the nerves to protect erectile function, but even then, there's usually some kind of an effect.
Right. Okay.
In losing prostate, the men lose semen, which means that when they have an orgasm, they don't ejaculate.
Okay.
There's an additional side effect, which is urinary incontinence. So men leak urine for a period of time, and that can interfere with sexual activity.
Right.
Radiation has an effect on erections over a longer period of time, up to 2 years, that erections become softer. There's less semen coming out over time as well. Orgasmic function doesn't usually necessarily change very much. And sometimes men have irritative issues with urination and with the bowels, and that can also interfere with sexual function, particularly for gay men if their bowels are affected and their anus is affected, then that can become a problem.
Okay. So you're saying with radiation treatment, it's often going to get worse over time. It's going to be a gradual decline in function.
Yes.
Okay.
And and because it is gradual, and because it's over time, and because the average man who is treated with radiation in his late 60s, men generally conflate it with aging, and so they don't react to it as strongly as when men have surgery. So those are so surgery and radiation are the definitive treatments.
Okay. And were you saying the ability to orgasm? I mean, I understand that they may not ejaculate, but the ability to orgasm, is that affected with either of those treatments?
It can be. So with surgery, sometimes men experience a less intense orgasm right after surgery.
Mm-hmm.
That can improve over time with stimulation. Occasionally, they experience a painful orgasm, and that also improves with stimulation and time.
Okay.
And with radiation, it should be reasonably unchanged.
Okay. But it sounds like a certain proportion of men are still going to be able to orgasm even after the surgery.
Absolutely.
Okay.
Yes.
Okay.
Yes.
I mean, it's it's striking to get a diagnosis like that and need to go through treatment, and then to have this additional sort of whammy on sexual function.
Oh, yeah. And I haven't even mentioned hormonal treatment, which is usually given to men either in combination with radiation if they have high-risk prostate cancer, or if they are diagnosed with metastasized prostate cancer. Hormonal therapy has a very strong influence on sexual function and sexuality because it basically deprives the man of testosterone. So testosterone is leached out of the body through this therapy, which slows down the prostate cancer growth. Men lose libido. They experience shrinkage of the genitals. They have problems with erections. Coming to orgasm can be more difficult. Not for everybody. There are some men who manage somehow to retain not so much libido, but some erectile function and orgasm. So I don't want to discourage men from being sexually active by any means. And, there are other side effects that are not sexual that can have an effect on one's libido and on one's comfort being sexually active.
Right, right. Are there any studies about men putting off or resisting treatment because of the loss of sexuality as they know it? I mean, it seems to me this could be a daunting choice for people. I mean, obviously you want to take care of cancer, but.
Yes. So there have been studies that have shown that some men would rather not have treatment than compromise their sexual function.
Mm-hmm.
And I have in my clinical practice, I remember seeing a man who had a PSA typically for a man in his A normal PSA for men is 50s, 60s is somewhere between, I don't know, 1 and 3 or so, or 4.
Okay.
And then as it rises, it becomes suspect for prostate cancer. Well, I've seen a man whose PSA was several hundred. It can go into thousands if it's really, really high. And that's for men who have much progressed prostate cancer. So men might just monitor their PSA and not undergo treatment for a long time, or if ever, to protect sexual function.
Right. I would imagine it's a big choice.
Yes, it's a really big choice.
How much are physicians talking about and concerned about sexual function, informing men about the risks of this and maybe strategizing about what to do? What should people be talking to their doctors about?
So people should be aware that any prostate cancer treatment has a potential sexual side effect. They should let their physician know that their sexuality and their sex life is important to them, and that they are interested in any available form of rehabilitation for erectile function so that they can remain sexually active with penetration. This would not be unfamiliar to physicians. They, generally speaking, make some effort to inform patients about side effects, although sometimes in the context of cancer, that gets a bit underplayed, and sometimes men end up being very surprised by what they discover after their treatment. So it's really good for men to be informed before their treatment so that they can ask those specific questions.
Right.
And then there are definitely some rehabilitation strategies that can be used. And there are also strategies for men and their partners, couples.
Okay, so let's talk about that. Although it did occur to me too. It sounds like they should be asking their surgeon if they're having surgery about sparing as many nerves as they can.
Yes.
Right? Like trying to make sure that they're preserving as much function as they can have.
Yes, so that would be a very reasonable request, and the surgeon will absolutely consider that because this is now pretty much a practice amongst many surgeons, and it will all depend on the extent of the cancer. So the first thing is to protect life, and so if it's impossible to spare the nerves, then that's how it's going to go. But the surgeons would very much respond to that positively.
Yeah. Okay, so what does penile rehabilitation look like? What's the best protocol for people these days?
Okay, so penile rehabilitation is a method for protecting the tissues of the penis from atrophying and from fibrosing. So it's not something that's actually directly related to recovering erection. It's just protecting the tissues while they wait for the nerves to recover. There are a number of strategies that have been used. Sometimes people use low dose PDE5 inhibitors such as Viagra, Levitra, Cialis, or now sildenafil, low dose every day or every other day to bring some oxygen into those penile tissues. In combination with vacuum devices to pump blood into the blood vessels of the penis to keep them open.
Okay.
So that could be one strategy. Another strategy is penile injections that do all of that at the same time. I should mention too that the vacuum devices, for example, and having a full erection stretches the penis. There is a certain amount of penile shrinkage that happens with surgery.
Okay.
So they help stretch the penis as well. And then a new method of penile rehabilitation is being developed in Scandinavian countries, especially in Denmark, and that is neurostimulation, using basically a particular form of vibrator to stimulate the nerves in the penis to stimulate erections.
Okay, so but all of that is just about maintaining the penile tissue.
Yes.
Okay.
So if men want to have erections, then the vacuum pump, for example, can be used to create a full hard erection, as can be penile injections. Usually the pills, the PDE5 inhibitors, don't work immediately, but may as soon as men begin to have some erectile function of their own.
Okay.
And another possibility is a small suppository that can be inserted into the tip of the penis to create an erection. So it's injections, vacuum pumps, and these small pellets that can be inserted into the urethra.
Okay. So, but that sounds to me like we're creating erections
Yes.
to preserve the tissue, but also potentially for sexual activity,
Yes.
right? I mean, it's two birds.
Absolutely.
Okay.
And there are also, I mean, I should probably also mention the fact that some men ultimately select penile implants, which is another surgery, to have reliable erections.
Okay. But that, I imagine, is not something people would consider in the short term, right? You want to make sure you can't regain natural erectile function.
Exactly.
Because that's a permanent change.
Yes, it's a permanent change.
Right.
Irreversible. Yes.
Right. Hey, I'm just taking a quick little break in the middle of the show. Most of you probably know, if you've been listening at all, that I have written a new book called Sex Without Stress. But what you may not know is that I have developed an online course to support you through the process. The book has a lot in it. It's a do-it-yourself process to totally transform your sex life, but it's hard to do it. And it's hard to do it alone without support. So I have been looking for a way to create an environment that's supportive and could help you actually get the stuff done. So what I've done is create an 8-week course. There are webinars that you can watch live or you can watch later. There's materials, there are exercises and directions, and then I'm going to offer live online office hours. This is where you can get questions answered and get input on your situation. It's not therapy, but it's a place to come and help you move through the process. The next cohort starts January 28th, 2019, taking enrollment all the way up until then. You can learn more at sexwithoutstress.com. Easy to find the online course information there if you want some more information. I would love to have you join me. Are any of those methods more preferred than another? You know, whether it's an injection or a vacuum pump or the electric stimulation?
It really more depends on the institution, how they do penile rehabilitation. So Memorial Sloan Kettering, for example, does penile injections. We at the University of Michigan do a combination of the pills and vacuum devices. When it comes to erections, it's a little bit the man's psychology.
Mm-hmm.
You know, many men, when you tell them they should be injecting their penis, look at you like you're crazy.
Yeah.
And so many men will start with the vacuum device, and either they like it, or if they don't like it, then they may graduate to penile injections, for example.
Right, right. Okay, so it's a mindset thing, I suppose,
Yes.
whether they're putting this device on to suck blood in, or whether they're in that injection. And I should say the injection is not a big, like hypodermic needle.
No, it's a very tiny injection needle that's very similar to a diabetic needle.
Yeah, like a finger prick.
Yes.
Okay. How long are men advised to do this? I mean, is this a week, a month, a year, a lifetime?
So really, there is no research that really can tell you how long men should do it. We recommend that men go on for 6 months. Some people continue to do it for a year.
Okay.
So it's a little bit optional, but probably 3 to 6 months is the minimum.
Okay. And this would be something that's advised whether men are going to, have a sexual partner or trying to have sexual intercourse, right? This is important for maintaining the tissues.
Yes. Penile rehabilitation is absolutely about just having a healthy body. Just like if you broke a leg, you would go to a rehabilitation gym. Mm-hmm. Or to physical therapy. It's like the physical therapy for the penis. And so men, whether they are partners, whether they're interested in sex, they like to be able to get their penis to as close a shape as they can, because it's not just about sex, it's also about body image. Men like to feel like their whole body looks normal.
Right. How frequently are people advised to do this, after surgery?
I don't know that we exactly have statistics on that. I think it's probably not that highly prevalent in many urologic practices. I think at academic institutions, it's more likely to be available because people are abreast of the research.
Oh, okay. So some segment of men aren't even going to be advised to do this at all.
Yes. And so if they sort of learn about it, for example, like from this podcast, they are much, much better equipped to go to their urologist and say, hey, I've heard about this thing, penile rehabilitation. If you don't know about it, can you research it? And can I do it?
Yeah. So how frequently do you advise patients to create erections?
So what we do with penile rehabilitation, we ask men to create full erections about 3 times a week.
Okay.
We ask them to masturbate, actually, also to have orgasms, probably 3 to 5 times a week. And so we are fairly aggressive in trying to get them to do the stretching, the blood flow, and the sexual response with an orgasm. So they can do that on their own, obviously. And if they have a partner, sometimes partners are very happy to be involved and be helpful.
Yeah. Okay. So having orgasms also serves a healing function?
So having orgasm basically just maintains the brain's kind of involvement in sexuality.
Okay.
It's just you want to keep everything that you're interested in doing going. So to
Okay.
speak. Yeah.
All right. So is there anything else that's part of a standard protocol from your perspective to regain sexual function, responsiveness, and anything else that they would be doing?
We basically routinely promote penile rehabilitation, regular creation of of erections and sexual stimulation. If men have partners, then we also encourage regular sexual activity as a way of, again, promoting the sexual recovery. And in this case, just not just for the man, but also for the partner.
Mm-hmm.
We what we do here at the University of Michigan, we have a very robust pre-operative education. So that men and their partners are very well informed about penile rehabilitation options for erections. They have sort of a little bit of an understanding of the physiology of it all and why it's important. And then we also follow up after surgery.
Okay. So what other advice would you give couples, who are going to face more complications, at least in their sex life? How much should they be emphasizing erection and penetration versus other kinds of sexual activity? Like, how do you talk to people about this?
Well, first of all, we ask people whether sexual activity is important to them, because for some people, they may have already given it up for other reasons and are not so much interested in sexual activity. So we respect that.
Yeah.
If people are interested, then we encourage them to be sexually active. We recommend that they do it a bit on a schedule, because a man's natural desire, even though he's going to have it, is not going to result in an erection. So most of the time, the man has to use some aid. We tell the partner that the partner is still a partner and not a tool of penile rehabilitation, so that has to be understood between the two. And we tell them that the erections will take time to come back, the natural ones, and that they should not over-focus on penetration. Certainly, they should have it when they want it, but they should also either return to or develop other ways of stimulating for sexual pleasure and for orgasms, such as oral sex, manual stimulation. We recommend vibrators and so on. So we tell people to not over-focus on penetration, but do it when they would both want to have it.
Yeah, and I would imagine that's a shift for some people, right? They may have narrowed, at least in my practice, right? I see people have narrowed down what they consider to be sex sometimes. And this is a challenge and I suppose an opportunity to broaden that again.
I would absolutely agree with that, because I think particularly these long-term couples who may have found a way of being sexually active that is very kind of, how should I say it, kind of efficient.
Yes.
And they go to, they go to penetration pretty quickly and achieve satisfaction through penetration. And so they have to either go back to things that they used to do before, or sometimes even learn new things. I've had patients who've had to learn how to have oral sex, despite the fact that in the past they had not been comfortable doing it. But, people, if they're motivated, they learn.
Yeah. Yeah. And at least, the good news is there are ways to enjoy each other still. Yeah.
Absolutely. 100%.
So in what percentage of patients who are diligent about the rehab, how likely are they to regain natural erectile function?
So some of it will depend on what kind of function they had in the first place. So if somebody already was using PDE5 inhibitors, we're not going to make them better. We're not going to get them. Mostly we do not get people exactly back to where they were, usually probably slightly below.
Okay.
Men who had really good erectile function have and are young and had nerve-sparing surgery have much, much more likelihood of returning to close to where they were before, but it's not completely reliable. Probably I would say, 15-20% of men get back to functioning erections.
15 or 20%. Okay. And so
Yes.
the remainder are going to be dependent on some of those devices or techniques.
On something. Yes. Eventually, PDE5 inhibitors may work for many men.
Okay.
And some men will end up using either vacuum devices or injections, or eventually go for the penile implant.
Right to the implant, which is, I suppose a good option if they're facing long-term impacts. Okay.
Yes. There are many men who don't want to have another surgery, and some are also worried about just losing that organ.
Yes.
Because if the penile implant fails, then there's nothing to go back to.
Right.
But, the research on men who have implants suggests that they're very satisfied with it.
Okay. Any final thoughts on what you would want people to know or understand who may be facing this?
Yes. A couple of different things. One is that when people start having sexual difficulties due to cancer, like prostate cancer, many times people are not used to talking about sex with each other because everything worked fine and they have a way of having sex comfortably. In this context, people have to learn to talk about sex, and it can be challenging. Number two, it's really important to engage in sexual activity and sexual rehabilitation early, partially to protect the tissues of the penis, but also partially to keep that connection and the relationship going. And when people are having a hard time, they should just get the help of a professional, like a sex therapist,
right,
or even any kind of counselor to just help them support what they're trying to do. But they should definitely not think that just because there are problems with erections for the man that they have to give up sexuality. Anybody who wants to stay sexually active can.
Yes, that's a wonderful point. So where could listeners learn a little bit more about you or about the program at the University of Michigan? Is there a website or some information that you could share?
They can just Google University of Michigan Urology, and then they could either Google my name or they could Google our Prostate Cancer Survivorship Program, and they should be able to get information.
Okay, I can put some of those links in the show notes too. So save people the Googling.
That sounds good.
Great. Well, thank you so much. I think this has just been, vital information for anybody who's, facing or might face cancer in the future.
Well, thank you very much for making this information a focus of your podcast.
Sure.
You've been listening to Better Sex. Please visit our website, bettersexpodcast.com, for show notes and additional episodes.
And that's a wrap for today. I really hope you enjoyed the episode. If you are enjoying the podcast, if some of this material resonates with you and you would like to make a difference and make sure that this keeps coming out in the world once a week, ongoing, there are a couple things you could do to show your appreciation. The first would be to go to iTunes and rate and review the show. That really helps us be found by new listeners when you review the show on iTunes. You can find a link at bettersexpodcast.com/iTunes. The other thing I want to invite you to consider is becoming a Patreon. For a small monthly pledge, you get some benefits. So for $2 a month, you get advance access to every single episode. For $5 a month, you get a chapter of my upcoming new book. And for $10 a month, I host quarterly get-to-know-you and question-and-answer chats over the web, and you get invited to that. I would love to have your membership in that, become part of the Better Sex family. You can find a link at bettersexpodcast.com/Patreon, which is Patreon. Again, thanks for listening. I'm glad you're here. Feel free to comment, ask questions, get in touch. I'd love to hear from listeners. Thanks.